Hi everyone, my name is Dr. Amos Yahav, and first I would like to thank you all for joining on board with us in order to lead the revolution of the new concept of dental bone graft cement in the dental field. So a little bit about us, who we are, what we stand for, and what we represent, and what we believe. So actually Augma Biomaterial is the pioneer and the world-leading manufacturers of bone graft cement for the maxillofacial and dental field. We don't believe in me-too product. Everything that we do is innovative. So in order to develop the perfect material, we need to understand our end user needs. And we split it into the needs of the patients and the needs of the clinicians. So what will make our patients satisfied definitely is if the procedure will be as safety as possible, as less aggressive as possible, that it will be with less pain, less swelling, and it will be short. No one wants to have a procedure that will take hours if he can do it in a few minutes. And of course, in the end, he would like to have his own bone back and not to have something else. And of course, the outcome should serve him for an ultimate functionality. So that's about the patient. Now, what about our clinician satisfaction? The clinician satisfaction will be based on finding a material that will be safe, predictable, and effective, that this material will require as less invasive procedure as possible, and of course that will improve his outcome, that the healing time will be shortened as well, that the chair time will be shortened as well, and of course that will increase his income and satisfy his patient. So all of those criteria are most essential in order to find a material that will fulfill those requirements. So let's try to understand what's wrong with the existing solution. There are three basic things that are wrong with them. First, all of the existing material up until now, they are unstable and they are difficult to be stabilized in the grafted site. It is time consuming and require high skill. The other things that all of them require membrane. So membrane is something that in addition, it's additional cost to the clinicians and additional time, and it's inhibit the healing. And the last things that those materials are integrate and do not regenerate. They are become a part with the bone, but definitely are not transformed into the patient's own bone. So for that, we invented a specific bone graft cement. So the question is, why cements? Because cement can simplify and expand our possibilities. The same has happened in the construction field, the same has happened in the orthopedic field, and now we have it here in the dental field. So I doubt if any one of you will light a fire in this primitive way when you have a matches in his hand. That's exactly what will be a few years from now. I doubt if any of our clinician will use membranes and granules when he will get used to the cement. And of course, don't forget that the happy customers is the loyal customers. Bone cement can provide us the most easiest and fastest way and most predictable way to perform our augmentation procedure. No membrane is required, and it does not integrate with the bone. It's regenerate the bone, it's transformed into the patient's own bone. So today I would like to show you two types of product. Both of them are based on the revolutionary concept of the Biphasic calcium sulfate cement. One of them is in the blue box, the other is in the red box. The blue box is called 3D Bond, which is a pure Biphasic calcium sulfate matrix cement, and the red box is a combination, a composite graft, which is made of 66.6 Biphasic calcium sulfate cement together with HA particles in a controlled particle size distribution. The blue box, actually, it's a short-term space maintainer, therefore its indications are limited to small defects such as socket preservation. We cannot use this box for using it in a larger defect. On the other hand, the bond apatite, the red box, is a composite graft that can be used in all types of defect, also for socket and also for larger defect. And of course, we will talk about it later on in my presentation. The invention is Biphasic calcium sulfate. This invention took us about 15 years of development. It was based on the most ancient material in the augmentation field. It was based on the simple calcium sulfate that exists for more than 100 years at that time. Now already it's 120 years. The problem with that material that it could not set in the presence of blood and saliva. Therefore, it was very difficult to work with him as a cement, and it resorbed very, very fast. So after 15 years of development, we created the Biphasic calcium sulfate, and it took us 15 years of development because we didn't want to add any polymers, no additives inside, to use its pure chemical structure, to be based on all of the literature that exists on calcium sulfate, and then just to improve its behavior. So Biphasic calcium sulfate, remember, it's the only calcium sulfate that exists today that can set and hard in the presence of blood and saliva. And the workflow is very simple. All we need to do is 3 simple steps. Place the material in the grafted site, press it firmly with a dry gauze pad for 3 seconds, and close your flap. That's all. It should be simple as we explain it here. And all of the surgical procedure is also less aggressive and less invasive and much more effective, because normally when we work with granules and membrane, we need to have tension-free on the flap with a primary closure. Here, on the contrary, the flap should be with tension, moderate tension, and the flap should be maximally closed. 1 or 2 millimeter exposure is not an issue, but not more than this. So we need to remember, it's less invasive to the patient and more effective for him, less swelling, less pain, and of course also for the clinician, he don't need to perform a very aggressive procedure. Here we don't use a membrane. We place it directly, the flap directly above the graft. So all we need to remember again, place, press, close. The flap should be with a moderate tension and maximal closure. So let's start first with the introduction of the Bond Apatite cement. Bond Apatite is the red box, is a composite graft which is intended to be used in all types of defect, in the small defect and the larger defect. It's a combination of Biphasic calcium sulfate matrix, 66.6%, and 33.3 hydroxyapatite in a controlled particle size distribution. Now, hydroxyapatite is not the astonished material to be used as a graft by itself. Actually, we use it here just as a stupid space maintainer, not more than this. But we did something very smart. We play with this particle size and shapes. So we have particle size which are started from 90 micron to 1 millimeters. The small to medium size particles resorb as well from 3 to 6 months. Already they resorb within the grafted site. And normally we know that hydroxyapatite is not supposed to resorb, but it's not true unless you give him the condition to do so. And that's exactly what we did here. So after 3 months, 60% of the grafted site is the patient on bone due to the transformation of the Biphasic calcium sulfate into the patient on bone. And this is 3 times more than any of the existing material in the market. And after 6 months, more than 80% of the grafted site is occupied by the patient on bone. So this is actually a part of regeneration and not integration as with the other grafts. This material comes with a very smart all-in-one syringe, so less mistake can be done by the mixing it with the saline that activate it. And as I said earlier, it's intended to be used for all types of defect, small defect, medium size, and large types defect. The beauty of this system is that the entire graft placement and stabilization can be done in less than a minute. Normally, a procedure that can take 20-25 minutes just to stabilize and place the graft can be done now in less than a minute due to the behavior and the characteristics of the cement, because as I said, place, press, close, 3 simple steps. You place the material, press firmly for 3 seconds and close the flap, the material set instantly. So in less than a minute, then the entire graft placement and stabilization can be done. The other thing is the healing period is reduced to 3 months. In 3 months, we have the patient on bone, so in that time we can place or load our implant, depend what kind of the procedure we choose to do, and no membrane is used, which save time and additional unnecessary cost, and of course do not inhibit the healing. In order to show you how it's work, we produced the following video, hands-on tutorial video on how to work with Bond Apatite. So let's see it together. I am Dr. Amos Yav. I myself am a clinician, the inventor of the Biphasic calcium sulfate, and the CEO of Augma Biomaterials. In this video, I would like to demonstrate how to work properly with bond apatite bone graft cement. Working with bond apatite bone graft cement can simplify dramatically the way that we perform augmentation procedure. The entire graft placement and stabilization can be done in less than a minute. The healing period is reduced to 3 months until you can place or load your implants, and of course, no need for membrane coverage as long as your soft tissue is primarily closed and well sutured. So, only 3 simple consecutive steps are required in order to place or stabilize your graft. You need to place the graft, press it for 3 seconds, and close your flap. So let's get started. In order to be familiar with the material, we provide you a training kit. The training kit includes training manual, 2 demos syringe of bond apatite, and mandible and a dry gauze. So let's get started. This is the bond apatite syringe. It contains the powder, the liquid, a shaft, 2 pistons, blue indicating line, and the syringe cap. Now, in order to activate the material, all you need to do is push the shaft against the palm of your hand and start pushing the piston until the first one reaches the blue line. At this stage, the material gained the right viscosity and is ready and prepared to be placed in the grafted site. Now, remove the syringe head. All you need to remember to do is 3 simple consecutive steps. Place, press, and close. And in less than 1 minute, you can finish the entire procedure. Now, let's do it together. Approach to the defect site in 45 degrees angle and start ejecting the material into the grafted site in 45 degrees angle. Now, during the ejection, use the syringe head in order to help you to stabilize the material by a small condensing movement that you do with the syringe head. At this stage, you should take a dry gauze, place it above the cement and press it firmly for 3 seconds. Now the material is already well stabilized. If you need to shape, you can shape it a little bit and press it again for 3 seconds and you can close the flap. However, it's very important that your soft tissue will be primarily closed and well sutured. That's all, simple as that. Now, I would like to demonstrate how to work with bond apatite for socket preservation technique when you don't reflect the flap. Press the shaft against the palm of your hand until the first piston reaches the blue line. Now the material is already activated. Remove the syringe head, approach to the socket site and eject the material into the socket. Slightly overfill it, and now you take a dry gauze and press firmly the material into the socket. Now, if there is not enough place for your finger between the teeth, use a spatula or an elevator peristyle and press above the dry gauze. Now you cannot leave the material exposed. What you need to do is to take a barrier, which can be a simple collagen sponge, and place it above the graft. However, it must be sutured together with the soft tissue. So the technique is in that way. Hold the collagen sponge in your hand, insert the needle from the buccal aspect, insert it to the bottom of the collagen sponge, and from up to down, insert the needle into the lingual aspect, and place the sponge above the grafted site and make your first suture to stabilize the collagen sponge in place. Now remember that the collagen sponge must be stabilized together with the soft tissue by its first knot. After stabilizing the collagen sponge in place, or the membrane in place, You continue with a crisscross suturing in order to protect it in a better way. Now the graft is protected and you can leave it exposed in that way. Soft tissue will migrate above the graft and will close the area. That's all. Now, after we saw it on a model, let's see a real case. In the following video, bone reconstruction was performed by lateral augmentation approach using bone apatite bone graft cement. As you can see in the CT scan, that the bone is very narrow, and at this stage it was impossible to place an implant. Even a narrow one, it was impossible. Therefore, we need to augment. So first we start with our vertical incision. As you can see, they are in a distance from the grafted site, and we do them with curves. We reflect a full thickness flap. And here you can see the anterior nasal spine and the depression of the bone that we have. When we release the flap, it should be minimal. The flap should be with a moderate tension, not tension-free as we used to when we work with granules. Because we want that the flap will be stable above the graft, because we don't use a membrane and it's directly on the graft, so we need to have it with a moderate tension. Here we activate the bone apatite cement within its smart syringe, and there are only 3 simple steps that are required: place, press and close. Place the material into the grafted site, press it firmly with a dry gauze for 3 seconds and close the flap. So here we eject the material into the site, press firmly for 3 seconds, not more than this, with a dry gauze. Now, if we want, we can shape a little bit, not too much, just to place it in place. Press it again for 3 seconds and close the flap. The flap should be closed directly above the graft, again with a moderate tension. If we will not have a primary closure, which means that if we have 1 or 2 millimeter exposure, this is not an issue, but don't leave it more exposed than this, because if it will be more, you might lose volume. Simple suture are enough, and of course the flap is very stable because we didn't release it too much as we used to do with granules and membranes. During the healing period, the patient wore a partial denture, removable one, but we relieve the denture and we remove all the buccal flange. Here how it looks after 3 months from the operating day. That's how it looks before, and that's how it looks after. So we gain now enough bone. That's how it looks before. And here you can see the bulk of bone, vital bone that we gained due to the replacement of bone apatite into the patient's own bone. We release the flap again in order to place an implant. We have a high quality of bone and sufficient amount that now we can place almost any implant that we would choose. It's very important that when we work with cement, it should be simple as we show here. You should get out of your granular state of mind and remember that cement is a different concept that must be treated differently, so you must work with it simple as we show here. Place, press and close. And of course, the implant have a very good primary stability due to the quality of bone that we gained due to the bone apatite replacement into the patient's own bone, and only after 3 months. That's all. Simple as that. And that's how it looks at the radiography after implant placement. The other video shows a different technique of using the bond apatite cement in socket preservation procedure. It's a hands-on tutorial on a model and in the clinic, how it should and how it shouldn't be used. So please pay attention and let's see it together. I would like to demonstrate how to work with bond apatite for socket preservation technique when you don't reflect the flap. Press the shaft against the palm of your hand until the first piston reaches the blue line. Now the material is already activated. Remove the syringe head, approach to the socket site and eject the material into the socket. Slightly overfill it. And now you take a dry gauze and press firmly the material into the socket. Now if there is not enough place for your finger between the teeth, use a spatula or an elevator peristyle and press above the dry gauze. Now you cannot leave the material exposed. What you need to do is to take a barrier, which can be a simple collagen sponge, and place it above the graft. However, it must be sutured together with the soft tissue. So the technique is in that way. Hold the collagen sponge in your hand, insert the needle from the buccal aspect, insert it to the bottom of the collagen sponge, and from up to down, insert the needle into the lingual aspect, and place the sponge above the grafted site and make your first suture to stabilize the collagen sponge in place. Now remember that the collagen sponge must be stabilized together with the soft tissue by its first knot. After stabilizing the collagen sponge in place, or the membrane in place, you continue with a crisscross suturing in order to protect it in a better way. Now the graft is protected and you can leave it exposed in that way. Soft tissue will migrate above the graft and will close the area. That's all. The second session demonstrates how it shouldn't and how it should be done. Because when you work with cement, it's completely different than how you work with granules. You should ignore all of your granules habit in order to work with cement. So here we can see the extraction. After the extraction, the material could not be used in increments like we do with granules. So suppose that you activate the cement with it in syringe properly. However, you cannot eject the material in increments or play with it like you work with granules, because as you can see, it's a mess and definitely it will never set. So this is the wrong way how to do it. And of course, don't use a tool to push down the material into the bottom of the socket. This is something that shouldn't be done when you work with cement. With granules we used to do it, but with cement not. Here is the correct way. Eject the material directly into the grafted site, press firmly for 3 seconds, remove the cement access, and then you must protect it by a simple collagen sponge, which must be secured with the surrounding soft tissue. So here is the collagen sponge, a simple one, which is not expensive. The only thing that you need to do is to trim it a little bit. You shouldn't adapt it. The only thing that you need to do now is to suture it and to secure it into the place. So first we do it outside, not in the oral cavity, in order that the sponge will not get wet, and then it will be much more difficult. Then, as you can see, we insert the needle into the buccal aspect and then into the lingual aspect, and we make our first suture. After that, with a crisscross suturing above it, we stabilize it in place. As you can see, there is no need for any adaptation, you just place it above. And that's how it looks on day 1, immediately after surgery. Now, there is no fear because soft tissue know how to migrate rapidly and safely above the graft due to the nature of the cement. That's how it looks 7 days post-op. You can see the proliferation of the soft tissue and the resorption of the collagen sponge. And after 12 days, you can see the suture inside, and during the removal of the suture, we can see that beneath there is the proliferation of the soft tissue above the graft. Of course, the bacteriostatic nature of the graft also helps a lot here. And that's how it looks. After only 30 days, you can see already start the maturation of the soft tissue. Of course, at this stage you cannot place an implant. You should wait at least 3 months until the bone will form and maturated in the grafted site.
The second product is the pure biphasic calcium sulfate matrix. It's the blue box, the 3D bond. The 3D bond is indication are limited for socket grafting from first central until second premolar or molar with the septum. This is a pure biphasic calcium sulfate, therefore is a short-term space maintainer. The benefit that it transforms completely into the patient own bone in 3 months. One thing we need to remember when we work with material that contain calcium sulfate, all the radiographic appearance is completely different than what we used to see when we work with granules that integrate with the bone. Those do not transform into the patient own bone. However, when we use the calcium sulfate or the biphasic calcium sulfate or the biphasic calcium sulfate with other product, there is an integration. Therefore, what we're going to see in the radiography is the first day is going to appear radio opaque. After 1 or 2 weeks, we're going to see radiolucency on the border. In 3 weeks, almost everything is going to disappear. At that stage, the clinician who is not familiar with it might think that he lost the graft, but actually it's the osteoid before calcification. We wait up to 3 months and then we see the calcification and the same trabecular form of the bone that is formed there. So then we see it radio opaque. So this is something which is very important, and it is important to explain it to our clinician. Again, also working with the 3D bone is similar. The entire graft placement and stabilization can take less than a minute. We eject it into the grafted site, press firmly for 3 seconds and close the flap. If we don't close the flap, such as we do in socket preservation when we don't raise the flap, then what we can do, we can place a collagen sponge which should be sutured together with the soft tissue as you saw earlier in the training video. So as I said, it replaced completely into the patient own bone. It's 100% of regeneration, and in 3 months, of course, you can place or load your implant. And again, as with any of our cement, membrane is not or should not be used if you want to enjoy from the benefits of the cement. And also here, if you raise a flap, it should be closed with tension, with a moderate tension, and not tension-free, as we used to do with the granules and membrane. In this tablet, you can see what are the indications and where we can use the 3D bond by itself, or when we can use the bond apatite, the red box. As you can see, the red box is for all types of defect. The 3D bond by itself can be used just for socket grafting or for closing a sinus window. However, if a clinician prefer to create his own cocktail, he can do it. We don't recommend it so much because it's much more complicated, but there are a nice video on the YouTube that he can see how he can mix the biphasic calcium sulfate, the pure one, the 3D bond, together with any types of granules that he prefer to use with. The next slide represents the advantages and the benefits of using our bond cements compared to all of the existing material in the market. It's the easiest and fastest material to work with. It reduces the operating time dramatically. In less than a minute, the entire graft placement and stabilization can be done. The outcome is much better because it's transformed into the patient own bone and do not integrate with the bone. And of course, the healing time is reduced from 6 months to 3 months, and no need for membrane, which save unnecessary additional costs. So all we need to remember, there are only 3 simple steps: place, press, close. And as we say, the less you do, the more you get. And as Leonardo da Vinci said, that simplicity is the ultimate sophistication. So I would like to thank you all for joining me in this session and welcome you to join us on board. Thank you very much.